السلوك الدوائية. And on behalf of all SPMACO members, I like to welcome you all to our webinar. And before introducing our chairman for tonight, I would just like to highlight about QR code for the attendance sheet. Please fill it out to get the semi hour, inshallah. So I will introduce Dr. Ashraf Al-Amir. Dr. Ashraf Al-Amir is a consultant family medicine, honorary assistant professor of medicine at Al Qura University, and chief medical officer at IMC Group. تفضل دكتور أشرف. دكتور أشرف سامعين يا شباب؟
ايوه يا سعيد، لو سمحت للدكتور اشرف.
دكتور أشرف أنت ميوت. دكتور محمد نور تسمعني؟
ايوه ما اسمعك.
طيب دكتور أشرف تسمعنا؟
اتاكد بس ان هو دكتور اشرف قلاوي ان هو يفتح المايك.
يس allow. دكتور أشرف تفضل. دكتور أسامة سامعنا؟ You are muted.
بس انتوا سامعيني؟
إيه سامعينك. حبيت أتأكد من الصوت.
طيب
دكتور اشرف حضرتك ميوت يا دكتور اشرف. دكتور اشرف. طيب يا سعيد اتفضل الانتروديوس دكتور اشرف تاني.
دكتور أشرف معانا. Just I will introduce you again إن شاء الله. أحد بس يأشر في الكاميرا. طيب I will introduce دكتور أشرف الأمير. دكتور أشرف الأمير is a consultant family medicine, honorary assistant professor of medicine at Al Qura University and chief medical officer at IMC Group. إن شاء الله دكتور أشرف سامعنا الآن.
يا دكتور اشرف حضرتك ميوت، يا ريت تفتح المايك. اتفضل يا دكتور اشرف.
دكتور أشرف سامعنا؟ مشكلة. معذرة من الجميع، فقط فيه خلل فني قاعدين بس نحله، فأعطونا بس دقيقة. دكتور أشرف تسمعنا؟ تفضل. أنا قدمتك، تكلمت، ناديناك بس ما أدري، كان في مشكلة عندك في المايك. ممكن تتفضل.
يا دكتور سعيد، الدكتور اشرف في مشكله عنده في الصوت، هو هيخرج ويدخل تاني فمعلش،
طيب
لان
ما في
في
مشكلة.
مشكله هو خالص.
طيب. المعذرة من الجميع، لكن إن شاء الله دقيقة دقيقتين راح نبدأ بإذن الله.
Can you hear me?
يس، نقدر نسمعك دكتور أشرف، تفضل.
اوكي خلاص
تفضل.
ابدا انا.
تفضل، حياك الله.
طيب اوكي. طيب بسم الله الرحمن الرحيم، الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this webinar, which is a very unique subject that we're going to handle today, which is a psychosomatic disorder when things start in a different place. And I'm very sure this is one of the major and a very frequent problem that we encounter, not only in the primary care and the family medicine practice, but also across the board through the different specialty in the medical field. So I'm honored today to be the chairman. I hope that this session will be quite interesting for all of you and very fruitful for most of you. But before I start, let me just set up the stage and pave the way by saying that we encounter a very frequent profile of patients who usually come to our clinic complaining of headache, short of breath, dizziness, backache, numbness, and according to these kind of symptoms, we usually take the proper history and then we do a physical examination and we might do more lab investigation, even sometimes more imaging, just to come up with a diagnosis. And unfortunately, the diagnosis comes with nothing to be concluded. And the pain and the patient will continue suffering the symptoms and he will question you to know what is the reason behind these symptoms. So this is exactly what considered that not all the symptoms are organic in nature, but it has to be considered as a psychosomatic disorder. So this will highlight the importance of the connections between the mind and the body and the need of the holistic approach to care for the patient. So that's why in our clinical practice, we use the biopsychosocial model of care, where we treat the body, but at the same time, the patient is not only a body, but he's a body, mind, and soul. So we have to explore the psychological problems, the social impact of the problem on the patient's life. So we are here, ladies and gentlemen. We have been privileged today to have Dr. Osama Al-Naimi, who is a senior consultant of psychiatry and addictions medicine, and he is the head of the psychiatry services in Kingdom Hospitals in the Kingdom of Saudi Arabia, and a medical director of Madarat Medical and Psychiatry Center. So we have been privileged to have him here with us to highlight and shed lights on the psychosomatic disorders. So I would like also to thank SPIMACO for organizing these education activities and supporting the continuous medical educations as we go. So thank you so much for joining us. And I hope that you can, as we go, just put your questions in the Q&A box so I'll be able to collect it, and we'll be having almost 20 minutes at the end of the session for the questions and answer. So looking forward to have a very fruitful sessions. And on your behalf, ladies and gentlemen, I would like to thank Dr. Osama Al-Naimi for accepting our invitations and being part of this wonderful gathering of today. So, Dr. Osama, the floor is yours.
دكتور أسامة معلش you're muted. You
Muted?
have to unmute it.
Again, you're muted still.
How about now?
Yes. Okay.
Okay. Thank you very much, sir, for these lovely words that you said. You just made my presentation more difficult because you just explained everything and I have to look for information for the guys to feed on. And then thank you, SPIMACO, for arranging this lovely gathering with our esteemed colleagues. If you allow me, my name is Osama Naimi. The word senior comes from my age, nothing else. So bear with me when I sometimes stutter. My presentation came after plenty of persuasion because I've been knowing this kind of information for some time. I read an article, then a study done by one of our colleagues here in Saudi Arabia, following up patients in the waiting room of a primary health care clinic, and they discovered that according to them, almost 2/3 of people in the waiting room were having sort of psychiatric complication in the form of anxieties or depression or other illnesses. And some of them were coming to this specific clinic because the doctor providing the service in a primary healthcare was so efficient in convincing them that their symptoms are a combination of somatic presentations, but probably of psychological stressors too. And that's why everybody got out of his clinic were feeling better. I had to dig behind and see if this thing is real, if this guy is not a magician or something. And I found a study saying that if you present to your client the information in a way that soothes their pain, 40% of their psychological complaint disappears even before starting any medication, which means if the same people who are waiting at the waiting room in front of this doctor's clinic, given any sort of assessment, and then directly after getting out of the clinic, they had the same assessment, 40% in average of these symptoms have subsided because he knew how to communicate with them and he knew how to present the information in a way that they could accept and probably work on for their future. Let's start from what are we talking about? We're talking about a combination of plenty of stressors in a form of anxieties, depression.
معذرة دكتور أسامة بس share السلايد. not share.
Already shared.
Share it again please.
Okay.
Sorry.
Okay. Okay. It's shared already. It's not?
No.
How about now?
No, not yet.
Let's see.
لكن the beginning share أيوة
Yes.
الآن واضح. Yeah, just expand it.
Okay, let's see if we can expand it from here.
Yes.
Very sorry for those technical issues. Let's hope it will not happen again. Yeah, how about that? Okay,
Yes.
right.
So
Yes.
as you understand from the name, it's a combination of psychological stressors. They either contribute and sometimes even manifest in physical symptoms, which means your client probably doesn't have, but sometimes they do have organic complaints, but these stressors make them worse in another form, and sometimes they present in a different form that if you have the time to talk to your patient, you can explain to them why their sensation is affecting their organic somatic complaints. Their pain, their complaint is definitely real. We are talking about clients who have real psychosomatic issues, and because we will reach a point where we can discuss with each other if the complaint is not real, a fictitious complaint, or if you believe that your patient cannot understand the way that you conveying the message to them. So we are talking now about people who have real complaint, and this real complaint is causing plenty of distress or even impairment in their life. Now, the common examples of psychosomatic that you definitely see, the most common one is the somatic symptoms. And the somatic syndrome was used to be called somatization disorder. You know, we psychiatrists don't have new medication, we don't have new illnesses. So from time to time, we change the names just to feel a bit appealing to our clients. We have the illness anxiety disorder, and I know that maybe you are overwhelmed with clients coming to your clinic saying that they have a specific illness that they read about, and unfortunately with the introduction of communication AI agents, it's becoming a bit nonsense to try to convince our clients that whatever they read on ChatGPT or Claude or Gemini is not the real presentation, the real diagnosis of their illnesses. Some of us who work in emergency rooms have faced plenty of conversion disorders. Conversion disorders were used to be called hysterical disorders maybe decades back because they thought that it came from hystera, and if there is a gynecologist, they will tell you that hystera is the uterus, because they thought it's limited only to ladies, and they thought conversion disorder happens because the uterus has twisted. After decades of investigation, they change it into conversion disorder, and usually they come to the ER complaining of conversion fits, conversion headaches, and conversion mutism, and some other combination of all of these. They come sometimes with chronic pain. Then this pain happens only because of the psychological stress, like when she faces an incident where everybody is shouting about her, or when he goes to work and finds that his supervisor is nagging behind his back. They have more and more pain, and unfortunately you cannot validate how much pain they have because you only have the relation with the stress at specific moment. We have the headaches, and if I'm not mistaken, we usually brag that headache is mostly, and I beg you to say that, mostly a psychological mental disease manifested in pain and other presentations of headache, because we know that there are more than 200 reasons for people to have headache, but 90% of them are unknown reasons, and from the rest of the 10%, 90% of them are related to stress. That's why we call it tension headache or stress related headache, and we want to confiscate this from our colleagues in neurology, but unfortunately they have better income, they have better clinics, so they have it for themselves. We have, of course, the most frequent thing that we quarrel with our colleagues in internal medicine is the irritable bowel syndrome. We understand now that there is some organicity behind irritable bowel syndrome, but unfortunately, plenty of our complaints in our clinic, which are related to anxiety, are presented with gastric manifestation. That's why we usually refer to irritable bowel syndrome as partially psychological, but sometimes we accept that it is organic. That's why, and you would see that during this presentation, we usually cannot confiscate all what's happening. There are sometimes organic reasons, but unfortunately they are made worse with the presence of the psychological component. They come with some common symptoms. I understand that sometimes they come with some weird symptoms, which makes it easier for you and me to diagnose that these people probably are not organic, and this helps me a lot when somebody comes to my clinic complaining of, say, for example, headache and then palpitation and then weak knees, and they want to do investigation for everything. And in my clinic, I try simply to stitch those complaints to them and tell them that it is probably impossible to have a syndrome that affects all of these organs, and maybe because the only thing connecting all of them is your psychological status, because you had these symptoms after facing that or after going through this. So we have pain, and I'm sure that you are aware of the role of pain in psychosomatic, but I need to remind you that this pain is bidirectional. So when somebody has a psychological pain, they will have somatic complaints, but occasionally when they have somatic complaints, it transfers into pain that is affecting their psychological status, and they go through this vicious cycle of coming to my clinic, then running after somebody else's clinic. They will have fatigue because they are tense all the time. They feel all stressed. They sometimes have dizziness or numbness, and these are the neurological symptoms of it. Of course, we talked about the digestive problems where they have distended abdomen, they have gases, they have constipation, sometimes diarrhea, sometimes acidities. They do have another autonomic nervous system symptoms like palpitation, the sweating, the cold hands, the cold sweat, and they have difficulty in concentrating because it is very impossible to some extent to concentrate where all your body is telling you that you are not well. Most of the causes and causative factors are related to stress, to anxieties, to low mood in a form of depression, to previous traumatic experiences, to maladaptive strategies that we usually use to cope with this pain in a form of isolation or misuse or self-harm. Misuse, I mean addiction, or self-harm, or extremities of behavior away from people, and sometimes because of the loud symptoms these patients are complaining of, their sensitivity to pain becomes higher, and this is why you might face somebody comes with a trivial pain in your experience, but in their valuation of pain they feel that is probably life-threatening, and it becomes difficult to normalize this pain if we kept on trying to put 1+1, because in their mind this is not 1, this is 1,000, and they need to get rid of it. The key mechanisms usually the psychosomatic disorder work on is to keep the person in a continuous state of tension. So their body is totally exhausted, their hormones are drained, they have higher sensitivity to whatever stimuli around them, even normal sensation looks like that it is on the higher level. Their capacity to interact with normal inflammation, to normal stressors becomes weaker. That's why they might have longer period of, say for example, viral infection. They will have more somatic complaint, they will have more dermatological complaint, they lose more hair, and she will have prolonged period because their body is always tense. And because it's tense, their hormones are tense and are excreted left and right, and their body is always bombarded with cortisol that makes the body itself unable, the autonomic nervous system and the other systems weaker, although they are on overdrive. And because of this much of tension, they cannot concentrate well. They behave in a way that they want other people not to see them in this situation. So they isolate themselves. They have less interaction with others. And unfortunately, sometimes they reach a point where you can definitely spot depression in them because nobody can understand and react to whatever complaint they are given. Giving that, I understand that you sometimes see the opposite of this picture, where more and more of the patients are coming with similar complaint to your clinic, and at the same time, when you come and value whatever complaint, you might think that this is a trivial thing. We call, and you call this, a cry for help, because they cannot um, use proper communication skills to tell you that they are stressed. They usually use their body to translate their pain to you. Um, the issue now is that we usually think of this patient as a frequent complainer, but what they do usually face when they come to your clinic is that because of this persistence of illness, this pain, this discomfort, they usually come more frequent than others. They cannot understand what's happening to them, and if nobody is having this capacity to explain it in a way to them or to the families, they will keep on coming because they cannot put in words what their complaint is. I need to remind you that because of many of them are of some older age, their capacity to complain mental embarrassment, mental complaints is less than more educated people. And it is easier to point at a point and say, this is aching me, than pointing at whole of your body and saying that this is what is aching me. And at the same time, I usually remind my colleagues that even with the vast development in the services, and we are being blessed by presence of people who've been trained and expert in their establishment, we still have social stigma when our clients come to any facility and try to complain of mental illness. They feel embarrassed because people around them telling them they are either lying or they are mad. People don't believe them because they keep on coming with similar complaint, even if they change the vocabulary for it. You cannot expect them to adhere to any management plan because they are not feeling better with your best management plan. As far as you and I would know, they cannot engage in activities, so they are socially withdrawn because they feel of pain. I know one of my clients who stopped attending all activities believing that he has backache and there is something serious about him. And although he had spent some of his life trying to find a reason for that, he finally agreed to give us the chance to help them in correlation and in with the help of his attending doctor, and hopefully he is now more interactive with others. Of course, these kind of clients, they face plenty of resistance, not just from the health providers, but even from their families and from their caregivers, because they keep on complaining and nagging about symptoms that nobody had that time to assess them well and know the causation for it. And because of that, although we are trying our best to provide the best service, it takes them longer than other clients to reach a diagnosis. And alhamdulillah, we do have some financial umbrella covering most of people that we know. But if we didn't, or if the patient wants to go and shop around, it will cost them plenty of money to reach a diagnosis that they can have. Maybe if they sat with somebody who is trained enough and open-minded enough to tell them that it could be something not just somatic, maybe a combination of your mental health and your body. So when this client comes to your clinic, please avoid these things. I know that most of you are swamped with clients who come frequently and they misuse your good nature, and they want to impose and maybe change the diagnosis in a way that suits them. I'm quite sure that at least once, twice a day, you'll face people who want some irrational diagnosis based on some chat with an AI or a stranger. I had an issue with my father today, who's 80 plus years old. He's a college professor, and he called me and said that he learned that mixing tomatoes with eggs are harmful for the kidneys, and he's asking me if it's possible to take him to a urologist because his kidneys are not well. To whomever doesn't know what mixing a tomato with eggs means, it's shakshuka, and this is my father who has like double PhDs. So me confronting him and telling him he is wrong will not give me anything. It will. The only thing is that you have to accept that this guy needs somebody to soothe the pain before telling him that this is not an actual pain. So don't dismiss the symptoms. Don't tell them that it is in their head. Don't try to mock them or ridicule them, especially in front of others. You will benefit nothing. And again, I do apologize that plenty of them come to your clinic, maybe taking some of your time, plenty of your time, and taking time from other clients. But unfortunately, this is what we sign for as healers more than doctors. And now I hope I have the time to tell you the difference. So how to approach these clients? The first thing that you should do is to validate the symptoms. You need to make them feel that you understand that their headache is real. Maybe the cause is different. You need to try to convey a message where you tell them that it is not just your hand that is in pain. Probably your head, your soul is in pain too, and you need to put that in a combination of words that is easier for them to understand without triggering any negative reaction from them. But please don't dismiss whatever they have, because they didn't come to your clinic. Again, I'm talking about specific kind of clients. They didn't come to your clinic because they enjoy coming to clinics. They came because they want you to find what's wrong with them, even if they cannot point at the place that they complain of. So I'm going to do this slide and then I'll go back to it. So our proposed treatment is an integrated approach. So these kind of disorders don't respond well to psychiatrists, they don't respond well to internal medicine, they don't respond well to gynecologists, they don't respond well to family physician. They respond to a combination and transparent relationship and a multidisciplinary team that will discuss each symptoms and try to find a causation for it, at least to help the patient understand if there is an organic reason and if there are no organic reasons. So in my clinic, I wouldn't do that. I'll give you an example. 2 weeks ago, I had a call from a friend from abroad that his mother started to feel dizzy, and they took her left and right, and they believe that she is probably trying to seek attention because she's becoming older and people are a bit occupied around her. But what he added is that his mother is having plenty of hypersensitivity reaction, and she's been having dripping from her nose for the last 2 years. Um, I am not a better doctor than anybody else. I'm still hoping to learn from everybody. I just asked for a proper assessment that includes excluding organic reasons. So we sent the lady for an MRI, CT scan, and we found big inflammation in her brain, and the cultural sensitivity was very peculiar because she responded very well to antibiotics. She felt well, but the cultural sensitivity was very peculiar because this kind of organism happens to be present only in feces. So we ended up we started up with a client that we thought that she has an anxiety disorder, and we marched through an organic reason, but we ended up with the same client with psychotic symptoms because she was collecting her leftovers and pushing them inside her nose. Of course, it's not always doctors who can do this thing. Psychologists, social workers, family members, even people who have influence on the patient, even if it was a religious healer who has some influence on the patient, can help with this thing. We used pharmacotherapy, of course, after making sure that there are no imminent somatic complaint that we need to clear first. Usually, myself, I like the SSRIs more than SNRIs. SSRIs are um, um, more palliative, more active. They cover wide range of symptomatology, anxieties, depression, and other things, and they are much safer for patients' body and have less side effect. Of course, the safest of them and the most frequently used is the escitalopram, like عريس الليل الانتابرو. Me myself, I stopped using tricyclic antidepressant, although I still see some of my clients coming from other colleagues. They prefer amitriptyline for their headaches or their joint pain, and it's a very valid medication. I stopped giving them for older people because of their side effect. I don't use anticonvulsant, but I know that as some prefer pregabalines. Alhamdulillah, because of the control of pregabalin, less patients are taking these medications. There is no question that it is helpful, but because of the tendency of misusing this medication, less doctors are willing to prescribe it. This includes physical and the rehabilitation because these patients have limitation of movement if it includes their musculoskeletal system. We need to teach our clients how to self-care, including their diet, including their exercise, sleep, stable environment, good relationships, social interaction. These things are as vital as giving them medication, but again, we cannot do that if we work as separate islands. It has to be a multidisciplinary approach where everybody has to disclose whatever information they have to the other members of the team, and eventually we reach a point where the patient will be happy. I don't think any of you will like to cultivate the win behind that. I think the best win we can be satisfied with is this patient is better, probably moving on with their lives. So just to take you into simple biochemistry, this is how serotonin and escitalopram are. Serotonin is made. It comes from one end of a nerve ending to the other end, from axon to dendrites. They are stored mainly in axons in specific vehicles, and when they are triggered, they move to the dendrites. They get absorbed there, and then they get cleared. But when they studied what's happening in anxiety and depression, they noticed that either the store of serotonin or the absorption is a bit disrupted. So they decided to keep the serotonin the longer time possible between those nerve endings in the neuronal plate, so it will be used more in to move to the axon than to the yes, to the axon than going backwards. And this would either by providing more serotonin, that will happen when somebody is abusing stimulants, or limiting the metabolic enzyme by the MAO, by stopping MAO from breaking serotonin, or by stopping the receptors in the postsynaptic receptors from taking more and more serotonin, so it will be readily available in this neuronal plate. And this is what all SSRIs do. They increase the accumulation of serotonin in the vesicles. They made it easily available to be sent to the area between two neuronal endings, and they stop the postsynaptic receptors from taking them and moving them forward. As I've said, I am a big fan of SSRIs, especially escitalopram, like Entapro, because of its efficacy from one hand, but it's not just the efficacy. Let me tell you how efficacious it is. It's efficient even in patients who have cardiovascular safety issues. It's very effective to clients who have hot flashes, and you can notice that it became better, although it's an organic complaint. It became better after giving the escitalopram. And even in cases of migraine, escitalopram, just like the Entapro, had proven to be very efficacious. It's safe, it's efficacious, and we've been saying for some time that escitalopram itself helps the cells, the neuronal cells, to stay intact, because we now believe that all our mental illnesses either have an organic origin or have organic manifestation, that mainly the brain is affected by how much anxiety and depression, and those SSRIs, especially the escitalopram in this case, preserve the neuronal component, preserves the mass of the brain, so the patient, when they go through their agony of anxiety and depression, they go out of it without having lost some capacities, especially in now we are concentrating more on the cognitive issues. So why should we as therapists care? Why do you have to care? Because these patients are exhausting your services. You can see if the study I started with is correct, it means between 6 and 7 of each 10 patients you're receiving in your clinic are psychosomatic patients. They have challenging symptomatology, and sometimes the symptomatology is irrational, but you cannot confront them and tell them, well, where the hell did you get this combination of symptoms? These patients, because of the actual presence, the real presence of pain, they don't adhere to a management plan without proper explanation and involvement. Again, all of that, we are talking about real patients with real complaints. In the middle of this all muddy symptomatology, a factitious issue will come. And I know that some people will abuse the service in a way that they will come to your clinic for the sake of coming to the clinic, sometimes to obtain some benefits, some secondary gain, like social insurance, that running from responsibilities, faking an illness, or collecting some insurance money, or sometimes even just for the habit of having a sick leave. And unfortunately, after all of that, we still have the possibility of misuse, where patients come to your service not to make use of it, but just for the fun of being there and having somebody as elite as you are on their service. And that's why they wouldn't mind coming frequently, because they wouldn't come as frequent if the service was limited. Now, again, going to the same treatment thing, I usually like to keep this slide presented twice. But this time we'll go from down to up. Treating psychosomatic disorder is not anybody's responsibility, it's everybody's responsibility. And when you have this thing, it will be very nice if you can convey a message to the client that you might need to pass by X or Y who would be more of help to you. Even if it was, let me refer you to our social worker, let me refer you to our psychologist, let me refer you to have therapy sessions, or even physical rehabilitation sessions. And this way you will tell the patient that you validate their symptoms, you didn't ignore them, and you are competent and qualified enough to understand that when help is needed, we should use it. It's not a one-man show, it's a team effort, not a personal effort. So let me finalize my presentation, and thank you before that because you were that long with me. What do you think? What should we do if whatever we said before didn't work for the patient? And I hope we'll have the time to discuss when whatever magic we are trying to bespoke on our patients is not helping them get out of these complaints. Thank you very much, and I'm waiting to hear from you if you have any questions.
Thank you so much, Dr. Osama, for this wonderful, elegant, very simplified presentation. You made the psychosomatic disorder very appealing to everyone. So thank you so much. And I think we have a couple of questions from the audience. One of the questions, Dr. Osama, how can clinician differentiate psychosomatic disorders or symptoms from organic disease without missing the serious pathology? So we have to eliminate the organic cause, the somatic cause, and then we go to the psychological one. So how to make the balance between these two different entities without compromising, missing a serious pathology?
Okay, let me answer this from two directions. One, from your point of view, and second, from my point of view. But let me start with mine so you will not feel victimized. Usually when a client comes to me, I like to ask them if they went to your clinic, if they made sure whatever they are complaining for has been seen and investigated and a conclusion has been reached about those symptoms before me pouring my ideas on. So if they said, I went by Dr. Ashraf, he did all the investigations you should think of, I went to another colleagues, I even consulted X and Y, but they all said, you do have this thing. But when I tried their medication, I couldn't get that much of benefit. But me, in my field, which is not so far from yours, I will take a proper history. I will make sure that all the checks are there. I will ask family members. I will try to find a causation that could trigger those symptoms. This is from my side. Before saying that maybe it's that, or in your case, it's more difficult. That's why you see, we accept case from you. We rarely refer to, because you are doing the magic. You are the guys who are doing almost all the heavy lifting. Because when somebody comes to your clinic and says, I only have headache, يعني الله يكون بعونك. I don't know how many tests and how many investigations and how many visits you have to see the patient before deciding, dude, I tried to find a needle in this haystack. I didn't find the needle. I didn't find even the haystack. Just go to Osama and talk to him. And the issue here is that while we are trying to do this thing in a collaborative ping pong thing, we always should understand that there are some room and margin for errors. Nobody can say, including Professor Ashraf, that they know everything. And I myself, when I gave you the example of this lady, I'm quite sure that I missed plenty of patients that I jumped into believing they have irritable bowel syndrome because their anxieties, and they tended up being having other organic reasons, including some serious organic reasons. So, first, don't believe that you are not going to make mistakes. You are a doctor, you are not a god. You tend to make mistakes. But if we work as a team, if I suspected that whatever history I've taken from the patient is not enough, I'll be more than happy to refer them to you. And if you believe that after all the investigations that you did, you believe that you might need to ask for somebody else's opinion, I'm here to help. I'll give you an example. When I was in medical school, our head of anesthesia training program gave us a question, a very simple question. If somebody choked and you cannot pull whatever they have in their throat, what should you do? So, of course, being fifth graders, we felt like we are supermen and women. And at that time, we came up with plenty of innovative solutions, including opening their throat, using the pen, using a pencil, using whatever. And all of that, all of us failed the exam. The answer was very simple. Ask for help. Look for somebody who knows better than you and seek their help. There is no point of being a super person.
Excellent. Well said, Dr. Osama. And this will take us to the continuation of the same questions. When the primary care physician should refer a patient with psychosomatic disorder to the psychiatrist? What are the criteria of referral? Because nowadays, depression, anxiety, and somatic disorder become part of the capability and the competency of the primary care physician and the family physician, because they are the first encounter with patients, and they maintain the continuity of care, and they are more accessible to the patients. And even many patients, they tend to come to the primary care because of the stigma, not to get stigmatized that they are patients with mental disorder. So we do whatever we can do, but again, there is certain limitations. So what do you think is the limitations, and when we should refer the patient to maintain the safety of patients?
I may add too that plenty of our colleagues are well qualified, and some of them are already certified to practice psychiatry, even if they started as family doctors. And because of their certification, and sometimes because of their vast experiences, they have better rapport with their clients than the rapport probably as an outsider will have, somebody like me. But as any job that you have in your life, any task that you have in your life, you ask for help when it is too much for you to handle. So if you felt that you can help the client and they are benefiting from you, whatever you are giving them, you are benefiting them, even if it was just for listening for them, even if sometimes if you repeated blood test every once in a while to tell them, don't worry, your blood is still well and you don't have that much of complaint. It is still, although you believe that you are not helping them, you are actually do help them. But when you see that either the patient is not benefiting from whatever you are supposing presenting to them, or if the complaint is keep rising, even with whatever issues they try to solve, or if you believe that this patient, and this takes me to the question at the end of the presentation, if the patient has a secondary gain behind that, maybe this way you will put them in a dilemma of being labeled as mentally ill or benefiting from coming to their clinic.
Okay, thank you so much, Dr. Osama. Again, I would like to make it clear to the audience and the primary care physician when we should start medications for psychosomatic disorder. Of course, we know that there is psychotherapy, there is CBTs, and as you said, physical rehab and self-care and others can be also part of the management. But if we exhaust all these elements, when we should start the treatment by SNRIs, SSRIs, and tricyclic antidepressants, as you said?
Well, I do I do get this question plenty in my practice because people are now more aware of the medication they use, and they believe that they can have a parallel help without going into taking medication. My answer usually is if it affects your functionality, you need management. So functionality is not just your job. It's your whole persona is being a mother, is being a father, is being a colleague, is being a son, is being a responsible person, is being a wife or a husband. If these things are affected, we usually prefer to start with medication, even if the psychotherapy is available, because we know that people admire and respect their functionality. So when it is affected, they don't have that much of time to spend sitting and trying to organize their thoughts in front of a psychotherapist. They need proper as fast as possible response so they can go back to their lives. When a study was done on depressed patients and they were asked, what do you expect from your management plan? The vast majority of them didn't talk about relieving depression. They talked about going back to their lives. So if their functionality is affected, please consider medication. If their functionality is not affected or partially and they can cope with the effect they have on their functionality, this opens the room for suggesting psychotherapy, spiritual therapy, sports, diet, or even supportive psychotherapy in form of nice people talking to them, reminding them how precious they are.
Okay, thank you so much. The consultation for patient with psychosomatic disorder, Dr. Osama, is very sensitive consultation. It's one of the very difficult consultations. Why? Because it requires certain communication skills. So what communication techniques are effective when discussing psychosomatic disorders symptoms, for example? Some people, they feel that we are interfering with their own personal issues when it comes to ask them about their mood and something that's related to their mental disorder. So how do you elevate this kind of barriers, and what are the methodology of communication you recommend us to use?
I don't envy any one of you when you sit in your clinic because I know how difficult your job is. It's really very difficult to try to tell people that they came with backache, but they should start considering anxiety disorders. And it's a very tricky uh, capability from somebody that is seeing that much of patient to find and spot mental illnesses in somebody who just came for headache, for example. So if we went back to the presentation, the first thing we should see is that we need to validate whatever complaint. We shouldn't tell them that it's in your head, because if you tell them it's in their head, they cannot trust you enough because they feel the pain, they feel the headache, they feel the dizziness, they feel the palpitation, even if your devices says something else. So start by validating the whatever they are complaining of, if it's pain or palpitation, and then try to put it in a way that it shouldn't always be organic. Sometimes being tired, sleepless, overthinking, concerned about others. I need you to notice that I used gray words that we use in everyday's life. So if they said, well, you know that I have this issue with my elder kid, if I have this issue with my wife, my husband being distant from me that time, I know this happened after I went to this place and everybody eyed me. From there, you can take them to explore other causation that is more into anxiety and depression. Because if I started by telling them what are the symptoms of anxieties you're complaining of, they usually shut down and nobody is responding to me. I need to put it in a way that they can agree on without feeling less mentally able. Again, the stigma is not always social. Sometimes it's a personal stigma because we've been risen on an idea that mental illness happen only to people who have less faith or have weaker personality. Nobody wants to have these.
Absolutely. So the open-ended questions, eye-to-eye contact, using the verbal and non-verbal communications, these are the soft communication skills that enable the patient to ventilate and to participate in opening his hidden agendas and highlight all the symptoms. طيب, Dr. Osama, if there is any screening tools for psychosomatic disorder, the way we have for depression and anxiety?
Guys, you are the best in that. Each one of you has at least 5 publications because of our tools. You can
Yeah.
use whatever tool you have. You have the primary health care questionnaire, the 7, 9, and 11, and extended. You have the Taylor. You have plenty. I hope that I can come to your clinic and have that much of knowledge because it's
Oh,
a. But if you want
we
my opinion and advice, train your staff to do that before they bring the patient to you. Tell them
absolutely.
that it is part of the job, just to
Yeah.
present it to the client waiting in the waiting room, and see that as if you are seeing any case and any lab results, and maybe from that you can decide if you want to do something about it.
Yeah, we usually distribute this kind of questionnaires and screening tools in the waiting area for the patient before he gets into the doctors. So it will be an opportunity for the doctor to look into this screening and validate the screen and then identify exactly what is the diagnosis. So Dr. Sama, coming to the end, if there is only one statement or one sentence you would like to deliver to the primary care physician to enhance their competencies and capability in managing patients with psychosomatic disorder, what would you like to say?
Well, it's 2 sentences. I'm very sorry I'm not always there for you guys. The second one is that I know how tired you are. I know you want to do godly work, but sometimes these patients, they don't have anybody else to talk to but you. So if you start your interview with your client with a smile, they will be more open to share things with you. And the more they share, the more they answer great questions, this will help you to ask more black or white questions.
Well said. طيب, thank you so much, Dr. Osama, for the wonderful contribution, for the great success of this webinar. And I think it was quite interesting for us to learn from your own experience and to follow your guidance, for the primary care physicians to navigate through the difficulties of handling patients with the psychosomatic disorder. So before we close, I would like just to conclude what we have said. So when it comes to psychosomatic disorder, it's a real challenge for all of us, especially in the primary care with the limited resources, and even for the time constraint that we have only few minutes. But I think establishing good doctor relationship and utilizing the soft communication skills to build up this kind of trust will be pushing the patients towards being an active partner to highlight his symptoms. So psychosomatic disorder demonstrate a very strong link between the mental and the physical health, as it was stated by Dr. Sama. And effective care requires looking beyond the physical symptoms. So most of the time we are so much engaged with symptoms and we exhaust all the resources to investigate by labs, imaging, and physical examination, but we have to identify the emotional and the psychological and the social influence of those illnesses on the patient. So that's why the best model of care that we usually implement in primary care is the biopsychosocial model of care, where everything will be highlighted without missing any component. Then again, I would like to say that the holistic patient-centric approach to improve the understanding and the management of this condition is mandated. So looking at the patient in total, don't look into the patient from a narrow angle, and try to do whatever it takes to put the patient in the center. And whatever you do should secure the best interest of the patient by a multidisciplinary team, as was said by Dr. Osama. It's not one-man show. It's a multidisciplinary team. So we have our colleagues in psychiatry, we have the psychologists and the social workers and the others, in fact. So the collaboration between the medical and the mental health professionals is very important and mandated to tackle this complexity of the disease and addressing both mind and body to improve the patient overall quality of life. So I like the statement which has been said elegantly by Dr. Osama. When it comes to the patient with a psychosomatic disorder, avoid confrontation, because you are going to destroy the flow of your of gaining the trust and the confidence of the patient to declare his feelings. And don't dismiss the symptoms. Don't tell him it's all in your head. So this is a total destruction of the relationship between you and your patients. And we have highlighted also the management could be in a multidisciplinary team approach as well. Psychotherapy and psychological therapy is one of the ways. And we have highlighted the medications, which is SNRI, SSRI, and tricyclic antidepressant. And I just echo what has been said by Dr. Osama. I always prefer the SSRI, like the citalopram, which is shown to be efficacious, safe, cardiovascular, and even accepted by the patients and tolerated by the patient as well. So with these kind of features, we have a very strong medication that take us all the way to another spectrum of managing a patient with psychosomatic disorder. So ladies and gentlemen, I would like to thank you for being with us here today. And I hope what we have offered you today was of an interest for all of you. So I hope that you carry along with you all the informations and all the expertise tomorrow clinics to manage your patient better, inshallah. So thank you, Dr. Osama. And I will leave the floor for the SPIMACO team.
شكرا دكتور أشرف، شكرا دكتور أسامة for the wonderful session and insightful session. شكرا لكم جميعا للحضور، تشرفنا فيكم جميعا. At the end I just will share the QR code for the attending again before leaving or ending the session. شكرا دكتور أشرف مرة أخرى and دكتور أسامة and all of your attending. حياكم الله جميعا.
Thank you
الله
so much.
يعافيك، يا أهلا وسهلا.